The next talk will be given by Dr. Krishna Nayak, and the title is No Field Cardiovascular MR. Thank you.
All right. Thanks for the introduction, and thanks for the invitation. This is my first time at MRI Club in a long time, so I assumed that this is a little more informal. So my talk's a little bit more informal. I'm going to show some unpublished results and give some candid thoughts about low field cardiovascular. So I have disclosures. The ones that are relevant are underlined. I received research support from Siemens, and I have NSF, NIH, and AHA grants related to low field cardiac imaging. So there's been a clear MR technology trend towards higher and higher field strengths, and probably the biggest winner, I think we can all agree, has been static neuroimaging, static spine imaging, static musculoskeletal imaging. And there's been many victories in other applications along the way, and that's the kind of equipment we've been able to do innovations on. What I'm going to talk about here is what's possible if we utilize all these modern high-performance components, but at a lower polarizing field strength. So Dr. Edelman, in his review talk earlier, he mentioned a 0.6 Tesla magnet with single-channel receiver coil and unshielded gradients. Here we're talking about a lower field system that actually has the rapid switching shielded gradients, receiver coil arrays, modern computing that we all love as seen from all the talks, and what we can do with it. So I'm from USC, and we're kind of an adopter of this technology. So on the engineering campus, we have an imaging center dedicated to this development, and I manage that center. And our children's hospital, which is 3 miles away, has ordered one of these systems and installing it next year. So we're very excited about it enough where, as an institution, we're investing in this direction. So the goals of our center are to develop technology to better understand health and disease. We focused on movement and not specifically to cardiac because we have a lot of users that span different applications beyond cardiac, including the airway, fetal imaging, musculoskeletal, GI. And so we do all of our work on a ramped down Siemens ERA system, which is ramped to 0.55 Tesla. Many of you are probably familiar with Adrian Campbell's Washburn's group at NIH. We have the identical magnet to what they have, and they're doing exciting interventional work on. So why low field? To summarize, there's many constraints that we experience as methods developers at high field. Notably, from physics, we have to worry about off-resonance. So the off-resonance from B0 homogeneity, also from susceptibility from the adjacent lungs, and also from metallic implants. We also, increasingly at 3 Tesla and 7 Tesla, have a consideration of B1 plus variation, which constrains our RF pulse design and often requires special design of B1 insensitive excitations. And finally, we have SAR constraints, which are RF heating, which scale with the field strength squared. So these are things that, as a methods developer, sometimes feel like handcuffs because, we have, this incredible flexibility with different pulses that the manufacturers provide, but we have these pretty strong constraints of what we can do with them. In addition, for interventional users, there's limited device compatibility that gets more complicated at higher field strengths because of heating of the implements. And from a comfort perspective, basically higher field scanners are louder. And often there's more challenges making it reasonably priced for the bore size. So for that reason, there's a group that is excited about potential for improved performance at low magnetic field strengths. And some of these improvements have been demonstrated, and I believe more are to come. There are many challenges, of course. There's reduced SNR due to polarization, and I'll talk about many ways we recompensate for that. There's increased challenge from concomitant fields, which are a bigger deal as you get further from isocenter and when you use stronger gradients. And that, in combination with gradient linearity, poses some unique challenges on the recon side. But again, we can leverage modern computing. And I think some of the optimism about low field plays to what Dr. Salerno showed this morning as 3 of the hot button concerns for CMR: complexity, scan time, and cost and access. So the low field systems have the potential to be lower cost and broaden access to MRI. As I'll show with improved real-time performance, there's a potential for shortening scan time. And for a complexity point of view, I think the pre-scan calibrations that we often do in a cardiac scan can be substantially reduced. All right. So let me start with some applications where there's a pretty clear benefit. This is an example from NIH where they have found that a much broader spectrum of instruments can be used during their interventional procedures. So they're doing procedures with MRI guidance in the suite, and the types of guide wires and other implements they were able to use was very limited at 1.5 Tesla due to heating issues. At 0.55 T, heating is reduced by about 7.5-fold, and they're able to use a much broader spectrum of instruments. Okay, that's one example. I'll just go faster. Another example is reduced artifacts from metal implants and devices. So when you're looking at this slide, I suggest you go left to right and start by looking at the bottom image, which is a 1.5 T image, and then look at the one on the top. So on the left, you see examples of valve clips and sternal wires, and on the right, you see the CIED examples. And so these are for different pulse sequences, but the point I hope you can see is that the artifact that's caused by the instrument is substantially reduced. And for most metals, the artifact is the susceptibility effect is proportional to field strength. There's a few metals where that's not the case, like stainless steel 202, but for most of the other metals, it's substantially reduced, to the point where you don't even have to use any special pulse sequences. You can just work around it. Another example is one of the constraints when we're doing imaging is SAR. So at conventional field strengths, we use SSFP imaging for looking at cardiovascular function, and we're increasingly using simultaneous multi-slice approaches. But these simultaneous multi-slice approaches involve using modulated RF pulses, and that requires substantially higher SAR. So for a SMS3 pulse, the SAR is about, 2.4 squared? So it's substantially higher, and this constrains the highest flip angle that you can use. But at a low field strength like 0.55 Tesla, SAR is again, pretty negligible. So it's 36-fold lower than it is at 3T. And that means that you can do SMS imaging at contrast optimal flip angles. And this slide shows that that's around 120 degrees. So 120 degree BSSFP with 3 slices at the same time. That's for maximizing blood myocardium contrast. If you're doing a myocardial tissue characterization, it's a lower flip angle that you need, so that's not exactly the same benefit. Many groups have been looking at real-time imaging and seeing if you can get adequate SNR and CNR with off-the-shelf approaches, but with modern reconstruction. This is a result from Ohio State. On the left, you see an example of Cine cardiac function imaging, and on the right is real-time, and you can actually see some arrhythmic beats. The quality is excellent. This is for Cartesian TrueFisp imaging with a compressed sensing reconstruction of some sort. But these images are rivaling what you would typically see at regular field strengths. You can see all the phases clearly. You can see regional wall thickening, and the contrast is excellent. Another opportunity to recover SNR is to just change our pulse sequences. At 1.5 Tesla or 3 Tesla, if we use SSFP, we're usually using very short TR. So for the pulse sequence developers here, at 3T, you often use a 3 millisecond TR, and with all the overhead of excitations and other gradients, your acquisition is only 1 millisecond or less, maybe 3/4 of a millisecond. So you're acquiring data for 1/4 of the time. And if you no longer have that same constraint on off resonance, you can use other sampling trajectories like EPI or spirals, and you can image for a much longer window in every TR. And so the NIH group has shown that you can use more efficient sampling, leveraging this fact, and recover a substantial amount of SNR. So we've been kind of feeding off of their work and seeing what we can do by pushing spiral SSFP to its limits. And I'm just showing an extreme example. This is unpublished work. This is real-time fetal cardiac MR. So there's no metric optimized gating, no assumption of periodicity. This is they're both in different moms, but the mom's breathing freely, the baby is moving around however they want to do, and we can localize 4-chamber views. We can localize and slowly sweep through the heart and great vessels and get a sense for, you can screen for potential cardiovascular abnormalities in the fetus in a couple minutes. And kind of a side bonus of this is that, again, the commercial version of the 0.55T scanner has an 80 centimeter bore, so it's also less claustrophobic for a pregnant mom, and the field strength leads to quieter scanning, which hypothetically will reduce fetal motion. That's the hypothesis, but that obviously hasn't been proven yet. Another opportunity is, if you're going to use spirals, you can, again, use the fact that you have a long TR to do creative trajectories. Here's an example from our group using spiral out-in trajectories, which have some nice moment balancing properties and give you multiple echoes that allow you to do fat-water separation. So you can do real-time fat-water separation. I mean, the quality of these is not amazing, right? But the point is you can see the coronary arteries in cross-section very clearly with an SSFP sequence. At a regular field strength, you'd have used some other approach, like maybe a spectral spatial pulse or something else. Here, we're able to do Dixon imaging in real time, which is interesting, and remains to be seen if this has applications. Okay, so groups like NIH and Ohio State have been trying to generate the comprehensive cardiac exam. This is an example from NIH, which is also summarized in Adrienne Campbell-Washburn's 2019 radiology paper, which I encourage anyone interested to read. She also gave a plenary at ISMRM in 2021, I believe. But the punchline is that the basic sequences, the basic suite of sequences can be replicated on the ramp-down ERA system, and Ohio State is a user of the commercial version of the 0.55T, and they're doing the similar studies at their institution with a little bit of a focus on obese subjects. NIH group has compared the output of cardiac Cine and LGE against 1.5 Tesla in the same subjects. They published this paper in JCMR a couple of years ago. The agreement was excellent between 0.55 and 1.5 Tesla. They also published a study in JACC Cardiovascular Imaging on late gadolinium enhancement. Again, the agreement was excellent between the two. LGE is one of the applications where the SNR and resolution, it really is, maybe it's closer to borderline than the other applications, but this is just an opportunity, I think, for more development. Ohio State has also done similar studies in a porcine infarct model. This is on a Siemens Freemax system with very nice results. You can see some first-pass perfusion and late gadolinium-enhanced images on the right two panels. Okay, so I also want to say that cardiac MR at low field, another exciting thing about it is the chance to do heart and lung at the same time. So the lung imaging at 0.55T has just been truly outstanding. And that's primarily because lung imaging at regular field strength is limited by the T2 star time, which is around 1 millisecond. At 0.55 Tesla, it's about 10 milliseconds. So you have substantially stronger signal from lung parenchyma, and there's opportunities to use new clever sequences for taking pictures of the vessels and the parenchyma. So here's some results from NIH using ultra-short echo time stack of spiral imaging. Looks gorgeous. This is with an 8-minute scan time, and they have published with this method in MRM. Actually, this was a young investigator finalist this year at ISMRM. And they have case studies in a variety of different lung conditions. What I want to point to is that at this field strength, SSFP lung imaging is also possible, which we might have thought was a little bit odd to think about because the T2 stars are so short. But even directly at the air tissue interface, you can actually take reasonable pictures. I'll skip these slides with a 2 or 3 millisecond TR. So here are some preliminary results that we've obtained in collaboration with Oliver Bieri's group in Basel. This is using their free-breathing B-star technique, which is a radial out-in technique. And you can get quite good, surprisingly good signal from lung parenchyma and blood vessels at the same time. And this is with a flip angle that was optimized for lung parenchyma. You can change it if you want to get better pictures of the lung vasculature. And then again, this is really experimental, but we're playing around with stack of spiral out-in, which is like B-star, but using spiral trajectories to make them more efficient. And this is in a single breath hold, so 25-second breath hold. And this is without we haven't implemented all the corrections we need for concomitant fields and gradient linearity. So this is just a work in progress. The Zurich group with Sebastian Kazurek has done some really exciting work taking a 3 Tesla scanner, ramping it down to 2 different field strengths, and evaluating many different aspects of performance. I just want to show 2 examples. First is the fact that cardiac gating is a piece of cake at low field strengths. The MHD effect is completely gone. And also, they've analyzed the gradient transfer functions and also acoustic noise. And as expected, the acoustic noise is substantially lower. And I think they have the best comparison, field strength comparison of acoustic noise to date. And that was presented at ISMRM last year. So in summary, I hope I've convinced you that low field CMR is exciting, but it's also still in its early stages, so please stay tuned. For engineers in the room, it's got different constraints from what you're used to at 1.5 and 3T, and I personally find that to be very refreshing, right? No longer concerned about off resonance and B1 plus or SAR. Instead, you're a little bit concerned about concomitant field effects and SNR, and you use different tools in your toolbox to address that. So it's a ripe opportunity for innovative pulse sequence design and new experiment designs, and even bringing new equipment into the MR room, because the compatibility of other devices in the MR environment is also enhanced at a lower frequency. For clinicians, there's an opportunity for interventional guidance with improved flexibility in what implements you use. You can do better imaging in subjects that already have metallic implants. With the wider bore systems, there's a chance to finally study obese subjects without having discomfort issues. There's opportunities in cardiopulmonary, given the dramatically improved lung imaging quality. And I think there's opportunities for better real-time imaging and even the multitasking MR fingerprinting approach, because unlike conventional field strengths, we have fewer nuisance parameters that you also have to model. So thank you for your attention, and I thank all these people for slide contributions and our team at USC.